Welcome to the Cancer Support Community's What's in Your First Aid Kit series. I'm Felicia Woods, Executive Director of the Cancer Policy Institute at the Cancer Support Community. We are a global nonprofit network of 175 locations, including Cancer Support Community and Gilda's Club affiliates, hospital and clinic partnerships that deliver more than $50 million in free support and navigation services to patients and families. We administer a toll-free helpline and produce award-winning educational and digital resources that reach more than 1 million people every year. We also conduct cutting-edge research on the emotional, psychological, and financial journey of cancer patients and advocates, and advocate at all levels of the government for policies to help individuals whose lives have been disrupted by cancer. Our belief that community is stronger than cancer is what led us to create this 7-session program for oncology professionals. We recognize that you, the cancer care community, are on the front lines of care. The care you provide impacts cancer patients, survivors, and caregivers from the moment of diagnosis and through end of life. We thank you for your commitment, your passion, and for your compassionate expertise. It is my pleasure to introduce you to our presenter, Dr. Lara Traeger. Dr. Traeger is a licensed clinical psychologist at the Massachusetts General Hospital Cancer Center and an assistant professor in the Department of Psychiatry at Harvard Medical School. She conducts clinical research as a part of Mass General Cancer Outcomes Research Program and the Benson Henry Institute for Mind-Body Medicine. Her research focuses on improving resilience and quality of life in adults affected by cancer. She also studies patient-clinician communication and clinician well-being. I'll now turn it over to Dr. Traeger.
Thank you so much, Felicia, for your wonderful introduction, and thank you to everybody for being here today. So I just wanted to start by saying I have no disclosures, and then wanted to briefly talk about what we are talking about today. So first we'll walk into what is moral distress, talking about what it is, what causes it, what are its correlates. We'll talk about how we can address moral distress at the system level, and then how we can address it at the individual and team levels. First, and before we even start talking about moral distress, I do want to say that, just as a caveat, that before we get started, that you as clinicians are the experts in what your experiences are and also what are the challenges that you face at your own institutions. And so I do recognize that not everything I say today in terms of the tips and the tricks that we suggest are going to fit for everybody. Not everything I say will fit everyone, but I do hope that there is at least something that you can pull from this talk today that makes it worth your while to be here. And the other thing that I will say is, another caveat is that when we are stressed, and I imagine that many of us are facing stressful situations at work that are putting us into the stress response, that when we are stressed, it's really hard to be creative. It's hard to try new things. And so I just also ask us all to give ourselves some grace when we're thinking about some of the strategies that we can use to address issues like moral distress, because it's important. So before we even get to moral distress, I just wanted to talk about what sets the stage for moral distress. I like to say that in the clinic room, it can get crowded because there's so many influences and demands on what we do. So think about all the ways that demands are placed on you during your day, not just the technical demands of your work. So there are some really unique factors in oncology that I think, again, uniquely set the stage for moral distress. So think about the things that go on in your day-to-day. We have patients who may be facing psychological or medical crises at all points along the cancer care trajectory. You have continuous exposure of clinicians to a life-threatening illness, often limited treatment options, and death. And then on the other hand, we also have growing numbers of long-term survivors, and they may be facing multiple and complex comorbidities. And we also have very ethically challenging situations related to care and often related to end-of-life care with varying preferences among clinicians, patients, families, and other staff. And so this is what we're grappling with on a day-to-day basis. So when it comes to moral distress, how does this different than just the everyday stress that we experience? We think of moral distress as a unique kind of distress. And if you're here for this presentation, I imagine you're either interested in learning about it or you know that you are recognizing it in yourself. This is a kind of distress that's in response to situations that constrain us from acting in line with our moral values. And there are a lot of different kinds of definitions out there. This is one of them. Basically, it's that mismatch between what moral actions ought to occur and what reality actually is. And I would add my own spin on this in a way, and I wonder what you guys would think about this too. But I often think that sometimes in these distressing situations, the moral or the right course of action is not actually clear to us. And that contributes to the distress because we know something is not right, but we don't actually know what the right course may be. And sometimes it's also not that the situation is constraining us from acting according to our values, but sometimes it's also about noticing morally distressing actions going on around you. So it may be that you're observing care being given in a way that is not aligned with your values, but you're not actually the one who's, driving the decision making. So let's talk about what causes this to happen, this idea of this mismatch between the morally correct or preferred action and what's actually going on around us. We have clinical situations that contribute to this. And this is not happening because, this or that person is just not doing the right thing. There are systemic things going on around us that are often outside of our control. Things like what we see day to day as the implications of healthcare system gaps, and then limited resources, and then inequities in how those resources are used or distributed. And then often we may have the belief that a treatment plan being given is not in the patient's best interest or in the interest of other patients and families. On top of that, then we have what happens internally for us, which actually contributes to that picture. If we are feeling that we don't know what we're doing, that we have a lack of efficacy, or we don't feel like we have the expertise, or we don't have a clear understanding of what's going on. And then you have even more external constraints. So again, this sort of gets the idea of moral distress being something that has many components that feel outside of our control and that objectively are outside of control. Things like when there's conflicts between policies and priorities of our hospitals and patient care needs, or pressure to reduce costs or to reduce risks. And sometimes there's even contributing factors in terms of the culture where we work, that issues of moral distress or the implications on ourselves and the impact on us isn't something that gets discussed openly. And I'm sure in the past year, as everyone has been grappling with the impact of the pandemic, both in our personal lives and in our professional lives, we've seen sources of moral distress related to the pandemic: lack of PPE, perceived risk to self and to family, amplification of healthcare disparities. This sort of adds to that bigger picture. So the next thing we wanted to talk about is to take stock in how we end up coping with these situations. I think this is so critical to think about, is how do we deal with this on a day-to-day basis? You may be coming here to learn about moral distress or learn about what somebody has to say about it, but already day-to-day you are coping with this and you're finding your ways about this. And oftentimes the way that we deal with it is different than maybe the way our colleague next to us is dealing with it. So one way of thinking about your coping, and I encourage you now, as long as you're on this call, to do a self-assessment, to ask yourself, where do I sit on the spectrum when I'm dealing with this in my work? One side of the spectrum we call internalizing, and the other side we might call externalizing. Internalizing is where we're feeling personally involved. We're contemplating our own role in what happened. We're feeling maybe implicated in it. Maybe we're feeling some ownership in it. And I'll just give some examples. These are quotes taken from a paper recently published in 2016. An example of internalizing might be, each case can cause a certain level of moral distress because I'm always reflecting on the choices I make and the steps that I take. Another example is if things do not turn out for the better, I contemplate what I could have done differently. So I'm wondering if anyone on this call, if that's resonating with you, if this kind of reaction where you're taking stock, what was my role in this situation, this morally distressing situation, if that sounds like something that your brain tends to do. On the other side of things, we have externalizing, where we have disownership, where we turn away from the questioning our own values and we focus on the external causes of what has happened. So here's just an example of that. I shouldn't doubt whether to start chemotherapy. There are evidence-based guidelines. And in the end, it's the chemotherapy that does or doesn't do its job. So you can see these are pretty different ways that different brains try to wrap their head around morally distressing situations. So I think here it might be helpful to just take a stop and ask Kara, who's on the call with us, if we could take a brief poll and see where we see ourselves. Sometimes you might find that, you're sort of on one side or the other or both, but generally what are your tendencies? Do you find yourself more internalizing, more externalizing, or do you really see yourself as a combination of both? Put your answer into the poll and let's see who's on the call. Let's see what we have. All right. So Kara, how are we doing? So we have, look how interesting this is. Did you imagine that not everybody would be coping in the same way that you are, that everyone's brain doesn't always work as ours does? On this call, we have 50% internalizing and some people who are doing both internalizing and externalizing. So it's really 50-50. I think that's really helpful to keep in mind because remember, when you are coping with moral distress, think about what happens when you maybe go to one of your colleagues for support or when they come to you for support, keeping in mind it's helpful to think about where you are on the spectrum, but also where your team is on the spectrum. And think about how that can actually affect team dynamics, team needs, and how to get those needs met. So you may be here to sort of learn about what you might be able to do for moral distress, but it's also helpful to think, how can I also support my team members who are going through this too? You know what? And the other thing to think about is any bias you might hold toward people who do a different type of coping than you do. Maybe you even have a bias towards people in other specialties who you see doing one of these things or the other. It's helpful to take a step back and say, what are the strengths of each approach? And then what are the challenges that each approach present to us? So again, we're not saying one coping is right or wrong. What we're saying is what are the strengths of utilizing one of these and also the challenges it presents to you and also to your team. So the next spectrum I'm hoping we can talk about here too is between focusing on the rational versus focusing on the experiential. So what does that mean? The rational is where when we're in a morally distressing or gray situation, we might pay attention to the theoretical or the academic rationale for what the choices that were made. Maybe we prefer formal deliberation about what happened to even out our feelings of moral distress. What are some examples of this? Here are some quotes from that same paper. What would help me are lectures about such subjects. So, okay, I have these experiences of moral distress. What I need is education to help me, maybe, to guide me. Or here, another quote, what helps with moral distress is a well-structured formal debate with all parties. You ideally have enough time for everybody to formulate their rationale. So when you're focusing on the rational elements, maybe you are thinking about doing this both internally, but also as a team. On the other end of the spectrum, we call this focusing on experiential elements. This is the concern about the experience of feeling. So not necessarily the formal structure or guidelines, but the feelings of everyone involved. Team discussions of informal ways of handling moral distress. So let's give an example of this. Our debriefings tend to focus on how can we get things done better and more efficiently. It's not that you can talk about how you feel and how a case affects you as a person. So the person who had this quote maybe would have preferred, again, talking about how they feel and how this case has affected them personally. So let's do a poll again, and let's see where we stand as a group here. Which one of us focuses on the rational elements, which on the experiential elements, in a situation where we're trying to cope with moral distress, and who does a combination of both? I'm curious to see this one. Okay, so here we have 18% focusing on rational elements, 18% focusing on experiential elements, and 64% focusing on a combination of both. So that's, again, really helpful to see because it actually shows us some of us do very different coping than others. And some of us do a combination of both. So maybe you're finding that one or the other isn't enough. Your brain needs both. So again, consider where you are on this spectrum and also take a minute, as long as we're on this call and we've set aside time to be here. Where do your colleagues stand in terms of this spectrum? What do you see happening in your clinics and in your units? Consider again, how do these differences maybe affect you and affect team dynamics and affect what each team member needs? And again, consider, do you have a bias towards others who may cope in a different way? Maybe a bias towards, different specialties and how you see them tending to cope. And again, neither one of these is right or wrong, but it's helpful to consider, how does this help me? How is this a strength, what I do? And how does it also present potential challenges? Okay, so for next, what I think is a helpful thing to do next is to talk about then what happens. So we know about moral distress, we've defined what it is, we've talked about different ways of coping with it. I want to go even further into talking about some of the terms we use that have kind of get tossed around, and we're not really sure maybe sometimes what the difference is between them, and our measurement tools aren't always good at telling us how to differentiate these things, but I'm sure we've all heard them. Moral distress, it's a really important topic because in turn, it's often related to something we call compassion fatigue, and both of those things end up potentially leading to what you have probably heard of, which is called burnout. So let's talk about some common definitions for these so we can start to differentiate them on this call. Again, we think of moral distress as that mismatch. It's our psychological response to those morally fraught situations where there's a mismatch between what we think is the right thing to do and what we see happening or what we're asked to do. Compassion fatigue is tension or preoccupation with the trauma of one's patient. Sometimes the symptoms of compassion fatigue have a little bit similarity to something you might see in post-traumatic stress, where you get hyper aroused to these kinds of situations. You might find yourself avoiding them, or sometimes you find yourself re-experiencing difficult situations of patient care that happened at work because of their intensity. And then there's burnout, which is a syndrome that results from chronic stress. So we think about this, that morally distressing situations are happening all the time. And with buildup of many of these experiences and symptoms can lead to exhaustion, cynicism, depersonalization, and a low sense of accomplishment, that you're not actually able to do ideally what you would want to do, and that it doesn't hold meaning, that you don't feel like you're making a difference. These are all really critical things to think about, and they are all related to each other. There are consequences at all levels, our own physical health and our own mental health. There are occupational consequences in terms of productivity. And there's also, system level issues as well, because a lot of these factors do lead clinicians to leave their work, which has multiple levels of implications. So the question is, how do we address moral distress? Is it even possible to eliminate it? I don't know how you guys feel about it, but I'm really curious. Does it feel like it's something possible to eliminate or reduce, or something that we just have to address when it happens? So the way that I think about it, and actually, if you want to put that in the chat, you can. Do you think moral distress is something that you can eliminate? Is it even something we can reduce? Or is it something we just have to figure out how to deal with and how to address and how to take care of ourselves when it happens? What do you guys think? If you want, you can put your responses in the chat. And Susan will help me with the responses.
Things that are kind of coming to me is that it depends on the specific situation. Mm-hmm. And that maybe we just learn how to adapt and address, but maybe we can't eliminate it.
Mm. Very thoughtful response. Okay, so I am going to talk about some ideas that others have had and that we have had in our work to address moral distress. Again, not eliminating it per se, but is it possible to reduce it? And is it possible to strengthen our ability to address it? Are there any other comments we should address, Susan, before we move on?
Yes, for a few folks, they're telling us that it goes on for years, these issues around moral distress, and not sure it's always a system or an organization priority. And there, maybe we can't eliminate it, maybe we're desensitized to it. So what do we do about that?
Right, that we can actually become desensitized to it and that it doesn't actually often seem like a priority. When I briefly went over the multi-level implications of not just moral distress, but its compassion fatigue and burnout, there's a lot more literature on burnout. There's a longer history of a literature on burnout, and there are some clear implications that may make sense to institutions and systems in terms of the implications at those levels. So I really think there's plenty out there to support the rationale for addressing moral distress. The issue is, how do we change culture? Because many of us in our trainings, we don't learn to wear our emotions on our sleeves. We're learning to sort of shoulder everything, that we're taking care of other people, but we don't need necessarily taken care of. So I think there's not always a clear impetus to addressing it at a systems level, but there's certainly a rationale for it. And there's certainly opportunities to change culture, even if it's difficult. So what I'm going to talk about now are some of those systems levels ideas. They're not easy to implement. They're not easy solutions, but they are some things that I hope can at least get your juices flowing. Like I said, you are the expert in your experience and what happens at your institution and how things work. So I'm hoping I can just sort of plant some seeds, and you can take those seeds and figure out how to sow them at your own institutions. I'm going to talk about multi-level approaches because I don't think interventions at any one level are enough. Okay. So, I mean, I think I will start by saying, when I talk about these interventions, I want to talk first about this presentation. I don't know how all of you came here and got to save an hour to be here. And I don't even know if you are having to work or answer pages while you're here with me. And so what I'm hoping to do is to later on ask you, what is pulling your attention away? Because one of the issues, I think, again, with programming for moral distress is that it's actually really hard to save any time in our brains or in our schedules to address this very important issue. And it really, I hope I've made the case about how critical it really is. And I feel like if you're attending today, you're on the same page with me. So I'm going to start by talking about some system level ideas. These are adapted from an ASCO roundtable that occurred a couple of years ago on burnout and moral distress. If you have time to look up that paper, I think it's an interesting one to read. So let's talk about one idea, which I think I went too fast, is to broaden our resources. How do we do this? If we want to address moral distress, how can we integrate it into our culture, into our current activities, into our exercises that we already do, so we're not having to wedge in new things, right? Are there educational sessions, workshops, training sessions, meetings, webinars, online resources that already exist that we can capitalize on and introduce like a curricula of moral distress into what's already there? Or can we consider developing new curricula? Is that something that will be necessary for our practices depending on where we are? Do you have, say, shorts rounds at your institutions? Do you have meetings that already are set up to talk about morally distressing or difficult, emotionally difficult, socially difficult cases? Or, again, is it something we have to develop in terms of curricula, or is it something we can integrate and infuse into other settings? And also think about, if you work with trainees, how can we develop resources and toolkits for trainees on communicating with patients, ethical decision-making and challenges, combating issues of moral distress, and also best practices for wellness in our setting. So if you are training new clinicians who are then going to go out into the world and practice, how can we help them understand what are the institutional factors that are risk factors for moral distress, and how can we help them look for those issues when they go on the job market? All right, and Susan, please feel free to interrupt me if any chats are coming in.
Great. I did put into the chat the
Sure.
ASCO reference.
Okay, great. Thank you so much. So the next broad area for everyone on this call to think about, could this be something we could do at my practice, is to establish quality metrics. I'm sure all of you are aware of some type of metrics or benchmarks at your institution that indicate success of some type of success. What if we were to create metrics or benchmarks, criteria, guidelines for positive practice settings in terms of clinician and staff well-being? Would that be possible? You can create the criteria, you can pilot them, you can see how they work, you can refine them, you can take the programs that have worked and you can make them more accessible to others. You can be an advocate in this area. If you found something that works for your team or your practice, get the word out, recognize best practices, highlight the people who are doing this kind of work. If people are winning awards in this area, or they have done small things on your unit, how can you amplify what you guys are doing and amplify those successes and get the message out? Also, how can you maybe do this even on a larger scale? If your practice has developed something that seems to be working, get the message out there, make that program more accessible, maybe put it online for others to access, maybe consider publishing your results as a QI initiative so that other institutions can read about what you've done, learn from it, and maybe adapt it for their own institutions. Maybe you can find that there are people already doing stuff like this and you can take what they're doing and learn from them. Start to create a network where you're sharing ideas so that we don't have to reinvent the wheel all the time. All right, the third area I wanted to just briefly touch on, again, these are just planting the seeds, this is not quick fixes, is the idea of research. Why do we need research? Even if you are not a researcher yourself, there's opportunities to contribute to the field, like we talked about in the last slide. But research is really important because how do we even know moral distress is happening? How do we shine a light on it? How do we amplify messages about it? We do that by being able to, in part, one of the ways that we can help to do that is by measuring it. And we have maybe one tool out there that helps to measure this, but we don't have a lot of data because it's not an easy thing to measure and to talk about. So the other challenge, I think, or the barrier to conducting research on moral distress is that, institutions like the NCI and other foundations don't often readily fund research on clinician well-being unless the study itself directly links whatever intervention is being studied, links it to a direct patient well-being outcome or a patient clinical outcome. And it's really hard to pull that off in any study, in pilot studies, much less RCTs. It's hard to do this, but I think there are opportunities to, again, start to get the word out about the importance of this kind of research, maybe support and promote internal funding opportunities, and support grant proposal development that might be happening at your own institution. We do need studies to clarify things like moral distress, defining it, showing how it's related to other things like burnout, more causes of burnout, the relationships between all these different factors, and also to study the effects of whatever programming we're trying to use to impact moral distress levels to show their efficacy or their effectiveness in real world settings. So that's my plug for research for those of you who have a hand in that and can make some kind of influence there. So now I wanted to talk about individual and team level strategies. And I'm very careful when we do this. And this is where I wanted to go back to that question that I was asking you before. If you can put into the chat, I'm really curious. And actually, Kara, I don't remember if I made this into a poll or not. If I did, please feel free to put the poll up. And if not, I'm just going to walk through this and we can put responses into the chat. But what I was curious to know, I did make a poll. Look, there I go. Great. Okay. So this is a program on moral distress. And when you're trying to be here and be present, like the slide said in the very beginning, Have any of the following pulled your attention away from this session? And I would love your honesty. I will not be insulted. Did you get pulled away, even at any moment, by a work email or page, other work tasks, personal or home tasks, like texts from your husband, which I just got while I was talking to you myself, or a combination of these, or none? So I'll be interested in your answer. All right, so what did we find? All right, so some people being pulled away by work emails, some by work tasks, some by home tasks, some by a combination, and some none. And for those who have not been pulled away, that's wonderful. I think that's fantastic. And I think it's also really helpful to figure out what is it that allows us to really be present and what is it that pulls us away? Because this is a realistic stage for what it is like to think about individual and team level interventions for work-related issues. We have to understand that there's 1,000 things pulling us away, and it's helpful to think about what helps us stay present. And those are the things we can also bring to our administration about what it's going to take to get people to be able to sit in their chairs and talk about this. All right, so I want to make the case for why individual and team interventions are important in the setting of like multi-level intervention ideas. I want to show the next slide because I just think this is really important to think about. There is that push and pull, and I'm so aware of this, that we're here telling people moral distress is a systems level issue. It's not in our control. It is not your fault. And yet, take this mindfulness class. You need better skills. How do we put these things together? How do we say moral distress is not our fault? It's not in our control. And yet you need to fix yourself. So I don't think that that's the approach we want to take. How many people here, and you can put this in the chat, feel like you're getting this message in some way or get frustrated with this message? How many people have another way of thinking about it? I'm curious to see what people say.
Yeah, so we've had some comments even related to your last Zoom poll, which is, that feeling when you have an upcoming vacation and yet you need to attend to other tasks and getting pulled even during this great session. But moral distress for me is working remote and all of the challenges it creates. That's a new distress.
Yep.
Feeling very disconnected, maybe not feeling as valuable or as effective. And that there's so many other distractions that lead folks to not feel like they're giving the care that they once have given. Mm-hmm. And then someone wrote in and just said, I think it's okay to not know and to know it's not your fault, but also learn tools to cope. Maybe they can coexist.
Yes. All of those things, all of them. I wish we were in person so we could really chat this out. But you guys, that's fantastic. And that kind of brings me back to that idea that everyone here is an expert in some way. Yes, remote work is hard. And I really am going to actually talk about that in a minute indirectly. But we can talk about it more directly if we have time. And yes, these two things here can coexist. We aren't to blame for morally distressing situations, and yet we still can find ways to cope with them, and we are worth figuring this out. So that's where I wanted to go next. I wanted to show this because it's so important to think about that even if these morally distressing situations, many pieces of them are outside of our control, they have very personal impacts on us in the moment. And so when you're, doing something where you're feeling all of a sudden disconnected with the patient, with a colleague, you're feeling like you're not sure what the playbook is telling you to do, and there is no playbook, you can have a stress response. And maybe you don't feel all of these things, but we certainly feel some of them. That increase in adrenaline, the increase in heart rate, increase in blood pressure, breath gets short, get tense, and that last bullet, memory, concentration difficulties. It is really hard to think straight. It's hard, like I said in the very beginning, it's hard to think straight. It's hard to think creatively. It's hard to think outside the box when we are in a stress response. And so no matter what no matter what's causing the stress response, we need something to help us with these very normal and real reactions so we can stay in the moment and stay in our day. And it's, the thing about the stress response is that the idea isn't to not have it, right? When you have a stress response in a morally distressing situation, it's not because you're not coping well. This is a human reaction. This is natural and this is normal to happen. So we're not trying to stop it from happening, but we do want tools when it does happen. And why do we want that? Because my next slide is probably, for me as a psychologist, one of my more important ones. It's the cascade that happens afterwards, that once we get into that stress response in any form that it's in, we start to change how we think. It is harder to think straight. It's hard to think flexibly. And so we start to think pretty rigidly. And when we do that, it can lead to pretty intense feelings. And from there, it influences our behavior and we get into this cycle. So I'm just going to give one example of this. Before you even become aware, oh yeah, this is a morally distressing situation, you're probably first in some kind of cycle like this, where you're starting to think something kind of rigid, like everything went wrong. Probably, and I don't know you and I don't know the situation, but I'm still confident in saying not everything went wrong, but we get that black and white kind of thinking. And you probably can also see this happen in colleagues. Like if you see a colleague with a really distressing case, you might hear them say things like, it was all, that person's fault. It was all that unit's fault. It was all my fault. I should have done better. It's painful to have these thoughts. It's also painful to hear your beloved colleagues have these thoughts. It can lead us to get exhausted. It can lead us to feel worn out. And when we feel worn out, what do? Some of us start to keep to ourselves. Maybe some of us lash out at others. And maybe some of us try to work even harder, which then gives us feeling even more worn out and then leads to even more rigid thinking. I'm not saying that this happens all perfectly exactly like this all the time, but I hope you can start to see, what is my cycle here? What does it look like when I get into this zone? How do I get myself out of this? But I will say that the reason why I focus so much on this is because when we have morally distressing situations, yes, we are skilled clinicians. We can find our way out of this. We can start to feel better. But then sometimes they creep back up when we're at home and we're back at work. These situations just creep back up in our minds. And then this is what happens. Those thoughts lead us to have these pretty intense feelings sometimes, this anger at the world, at ourselves, or like one of the people in the chat said, you might actually shut down and be desensitized and stop feeling anything. Or you might feel guilt, or you might find yourself blaming yourself or others. So that's kind of like a cross between a thought and a feeling. But these emotions are not easy to disentangle ourselves from, and they are painful. And so, yes, morally distressing situations we aren't to blame for them, but the consequences of them on our emotional well-being, we merit the time and attention to strategies to deal with them. Again, these are not signs that you are failing at coping. These often are pretty human responses to have, and we need help with them. And it needs to be part of our job because it's a job hazard. So one of the things that I highly recommend and encourage everybody to do is when you start to have these very strong feelings, rewind the tape and really see what thoughts are related to these feelings. Really challenge yourself to find those thoughts and start to break them down. Thoughts like, no one cares, it's their fault, or it's my fault. Everything went wrong. These are tough to have. And for the person who said, I am getting more moral distress from working remotely, that's an issue because there's no one next to you right away to help you reality test when these thoughts come up. If you were to say, I should have done more, your colleague next to you could say, actually, there isn't anything else you could have done. And sometimes that's just enough to hear. But when you're working remotely, you don't have that. Or if you have a team where, again, they're not coping experientially, they might be coping more rationally, you may not have an audience or a place to talk about your feelings if that is the type of coping that is helpful to you. So what I suggest is the idea of widening our lens. Can we widen our viewpoint? Can we get unstuck from these feelings? And I would say that the interventions at the individual or the team level, at the base of them, this is what they need to be doing, is to help us get unstuck from these feelings, not necessarily pick the right solution to the clinical issue or find a way to fix the inequities that we see around us, although that can be a long-term goal, is in the moment to deal with the stress response that just got kicked off, that's making my brain get spit out these very rigid thinking and cause these very intense emotions, that we need some tools to deal with it when that happens, to be able to tolerate those intense feelings while kind of unwrapping them a little bit and making sure that our thinking about situations is as clear and as helpful as it can be. And so, we talk a lot about the importance of teams in doing this. It really is helpful to think about what are the strategies that you use to maybe help yourself get unstuck. And I ask you guys, if you want to even put this in the chat, I'm curious about this because I do a lot of group supervision with oncology and palliative care clinicians, and I see all different kinds of social support coping going on. For you, if you are the kind of person who does need to process things a bit, do you find it most helpful to process a situation with the care team that was involved with the case? If it is a case that's causing it, do you find it more helpful to debrief with, let's say, maybe debrief isn't the best word, but to talk through things with a colleague who wasn't part of the case, but maybe is in your discipline? Like, let's say you're a social worker, another social worker, or you're a nurse, another nurse who's not part of the team, but is a colleague of yours and kind of gets it, right? Or do you find it more helpful to go home and talk to somebody in your personal life about it? Where do you tend to go where you feel the most understood or you get what you need? Who is in your foxhole? So what are people saying, Susan?
Some folks are saying that they take a step back and reflect and then seek some consultation. Folks are saying kind of a combination of all of those things. First discussing it with the team, and then maybe a trusted loved one or a partner. That some folks are even saying that when I was not remote and was on a team, that was kind of an easier, approach. But maybe you can talk a little bit. I know that, I can see who's attended, and we have a lot of folks that are remote, some because of COVID and some because of just where they work. And so what are some suggestions on how, when you're widening your lens and you literally don't have anyone to walk down to the next cubicle to, what are some suggestions for folks that are remote?
So what I would say to that is to recognize, yes, I know this doesn't sound like a lot, but it is. It's to recognize, yes, this is hard. Yes, I do need a team around me, and no, I don't have that. And reflecting on what is lost and grieving that. And then recognizing how important it is to see, are there ways to create that? And it does take effort, especially some of us who are introverts who aren't used to necessarily, spilling our lives out to people proactively. It is hard to put that together. And you may not know if other people on your team or in your unit want to, but it's worth trying to put yourself out there. I will say that I do meet with clinicians and fellows every week, every other week to kind of go talk about these issues of moral distress. And I've noticed that since we've had to move our sessions to remote, we're all meeting by video conference, not in a private conference room. And it has suffered. I'm not saying it's not worth it at all, but I recognize it is not as powerful as it can be for some things. So when we have people who are Zooming in to be part of this group, they are calling in from, clinic spaces that might not always be private. So they might be at home where they also may not have privacy from other family members. So it's actually harder to talk about what's hard. It's harder to, complain about a colleague. It's hard to complain about something when you're not next to somebody and being able to read their body language about how they're reacting to what you're saying. So I found that on our calls, people may be less likely to open up. What's been a little bit more helpful is when we've done more breakout sessions where it's just smaller groups. And so for some reason, when we're in a smaller group, people find naturally it's a little bit easier to open up about those hard things. Not necessarily, technically hard cases, but really just those distressing, morally, emotionally, whatever kinds of distress cases there are, or situations, even interpersonal situations. It doesn't even have to be about a case. That smaller sometimes is better. At least that's my reflection. And I'm sure people here also have ways that they've come up with to try to bridge the gap in collegial support. Does anybody else here have any other ideas they want to throw into the chat?
Yeah, something came through just directly to me, and the kind of around both a reflection and a question. Just based on the what you've shown us on what moral distress looks like and feels like, it's isolating in and of itself, right? If the first responses are it's someone else's fault, or it's all my fault, or everything went badly, already you are set up to maybe have a difficult time even widening your lens, because the statements we use in moral distressing experiences already closes and makes us more myopic. And so it's a setup from the beginning, right? Both as we anticipate something that could be morally distressing, as well as going through it as a team. And so it's more of a statement. And then another response has been working remotely maybe hinders us from keeping work and personal life separate. Mm-hmm. And so therefore, it has a cascading effect of stress, because you're dealing not only with the stressors from work, but there isn't that commute from the office to home before you're preparing for the stressors at home. It feels like it's a kind of a deeply stressful time for folks in the oncology space.
Absolutely. And these are really astute observations. I want to focus on both of those. The first one is about that sense of estrangement, because the moral distress does lead to thoughts of estrangement. It leads us to shut down our empathy. We see the situation in black and white, and we see other people in black and white, that they are, it's a human thing. We just become that they're all good or all bad. It's really hard to get out of that, because then if you're thinking of humanity as bad, how do you then reach out? And again, I can come up with some little things off the top of my head, but I guess my point is we've got to kind of stay creative about how we address this. So for example, if we have trouble reaching out when something like this happens, do we set something up where there's a peer that we look after each other, that you just call to check in, and you kind of push your way into someone's day. And even if that's a few days after the morally distressing situation occurred, I believe that sometimes those situations stay with us. So it's still valuable that even a few days later, if somebody is pushing their way into your life and checking in on you, that there's still value in talking about it then. And if you need that, you also can be that for somebody else. The other issue of, the separation of home and work, it's true. I have to, think about that too, because I'm calling you from my home. So outside my door is my personal life, is my laundry, is my dinner. It's everything that I have to get done. It's a really hard thing to do. So think about what you have in your day that you have to do. So for example, this is just my life, but I have to leave my house at a certain time every day to go pick something up outside of my home half the week, and it forces me to get outside. And on those days, I don't like it because I have to leave everything in a mess, but it helps me get a fresh air. And on the days where I don't have to do that, maybe I tidy things up at home, in terms of my work emails at the end of the day, but I don't get that fresh air. So sometimes forcing ourselves into a structure, remembering that this year has been so new, we don't have those structures in place, and we have to create them. But I am not a wizard. And what I'm saying mostly is, if anything, take the time to recognize what you're talking about and value it. Value the challenges you're facing, so that then you value the time to try to come up with things to try. But none of us have every solution. But if we recognize that the problem is worth attending to, that's half the battle. just in terms of wrapping up, I throw all these terms out there. I don't even know if anybody has heard of all of these or none of these, but I just wanted to say that the data is showing us that there's not that much data out there on what could be helpful, but all of these probably could be helpful in some way because they're getting at the idea of tending to the intense feelings and emotions that can come up in these situations. So I encourage you, if you have sort of a preference for any one or the other, that any of these could be helpful. And the way that they can be helpful is two things. Making the time and making the compensation. So how do you help your practices protect your time so you can actually engage in these? And can you get continuing education credits? Can you get some kind of compensation so that you actually can turn off the work email and really participate? So I will stop there. I think I maybe just have one more slide, which is my soapbox that we have to promote the culture to make this happen. And I'm happy to answer maybe one question before we probably have to move on, or we can talk about one comment that's come in.
There have been comments around kind of feeling lost in our ability to communicate effectively because of the remote work and the social isolation that we all experienced over the past 18 months, and that once confident professionals are now not feeling as confident or competent in even, reaching out to their colleagues and staff. And so we'll leave it at that if you want to address that.
Yeah, I mean, that's such a critical thing, is that loss of confidence. I think there's a real hard line that has to be made between I don't know the answer and I'm not smart, right? Or whatever it is, it's really rigid thinking that when we lose our confidence in a situation and what to do about it, it becomes global, it becomes whole encompassing, and we have to push ourselves out of that. We have to be able to reality test those thoughts. And in this time of more isolation, it is harder. And we do have to push at regaining our social connections. I really do believe that. Thank you guys so much for being here and being part of this conversation. Clearly, this is an important topic. And if you feel you've got so much to say on this, keep talking about it. You don't need me here. Talk about it with everybody in your life. Keep the conversation going. And thank you so much for your time.
Great. Thank you, Lara, so much for being with us. I really appreciate it. And I think I appreciate your really frank discussion on this topic, because it is challenging and it's something that not everyone feels comfortable talking about. So again, thank you so much for just the real thoughtful strategies that you've offered to all of us. And to all of you on the call, on this webinar, thank you so much for joining. We appreciate you taking the time, and we know it is important to you. So thank you again. Just so you know, we really appreciate your feedback, and there will be a survey at the end of the session. Right when we end, a little kind of button will pop up. So please take the time to fill that out. And this really couldn't have happened without the sponsorship from two of our companies here. So Merck and Takeda Oncology. So we just like to thank them for giving us some funding for this project. And then last but not least, we have one more session coming up in the workshop series, and that is by CSC's own Eukarya Borden. And so Lara gave us a really great introduction onto those systemic barriers. And it's not always, we can always just throw tools out. There are some real systemic issues coming into play here. And so Eukarya will be just discussing those issues with some particular emphasis on health equity and diversity. So please join us. It will be July 8th from 12 to 1 p.m. Eastern time. And if you do have any questions, feel free to reach out to me or Susan. So thank you, everybody. And thank you again, Lara, for joining us.
Thank you very much.